Hello, my name is Hagit Levin, and I am a pediatric pulmonologist at Schneider Children's Medical Center. As you all know, Duchenne is a devastating disease, X-linked inherited neuromuscular disorder due to mutations in the dystrophin gene, which cause skeletal muscle weakness and wasting, and also the respiratory muscles will also be weak, which will cause restrictive lung disease. And historically, respiratory failure has been the leading cause of mortality and morbidity in Duchenne. Along with other muscle wasting, the respiratory muscle weakness, which will cause a decrease in the vital capacity. Also, weak paraspinal muscles will cause less support of the spinal ribs and kyphoscoliosis. All will cause total lung capacity and compliance, which will decrease. The restrictive lung disease is progressive and causes hypoventilation. Respiratory complications are a major cause of morbidity and mortality in people with Duchenne. Complications include respiratory muscle fatigue, night hypoventilation, mucus plugs, atelectasis, pneumonias, and respiratory failure. If left untreated, patients are at risk of severe dyspnea, length hospital admissions due to atelectasis or pneumonia, and death due to respiratory arrest or respiratory-induced cardiac arrhythmias. We at Schneider Children's Medical Center work together in a multidisciplinary team in order to improve the quality of life and the respiratory condition of Duchenne patients. We work parallel to the guidelines that were published at the Lancet Neurology in 2018. Treatment and follow-up vary according to the different stages of the disease. There are 5 main stages: the pre-symptomatic, the early symptomatic, the late symptomatic stage, where a patient is still walking, and stages when the patient becomes non-ambulatory, sitting on a wheelchair. The non-mobile late stage is the multi-complicated stage. Patients are generally advised to attend a semi-annual review to meet with a multidisciplinary team. Of course, in the early stages, they can see less as in the later stages when they should be seen more. Pulmonary assessment and treatment are different at each stage, but begin in the early stages, even before the respiratory symptoms. Even in the early stages, from the age 5 to 6 years, we monitor lung functions. Most evidential functions will begin to decline even before the patient will complain of respiratory symptoms. The age at loss of ambulation is predictive of FVC decline. As you can see, FVC rises with growth until an individual becomes non-ambulatory. Then the FVC reaches a peak, follow a plateau, and then deteriorate over time. We saw in previous studies that systemic steroid treatment slows the rate of deterioration and respiratory disorder, so it is important to treat steroids from early stages, but even after a child is no longer mobile. Even then, corticosteroids still help to reduce the rate of respiratory deterioration. At the same time as monitoring lung function, it is important to perform annual follow-up by sleep study to ensure that there is no nocturnal hypoventilation and CO2 accumulation. The sleep test can also help the follow-up for children who are unable to perform lung functions. Also, a light steroid treatment can cause obesity, and obstructive sleep apnea may form, which is also an important cause to do the sleep studies and to diagnose obstructive sleep apnea and treat it if necessary. In early stages, we treat our patient with active and fun respiratory physiotherapy, such as blowing soap bubbles, swimming, hydrotherapy, using tree flow devices. Also is a practice active physiotherapy. And then later at late stages, a passive professional physiotherapy is recommended. Already in the early stages, we encourage vaccinations against influenza and pneumococcus. When the patient weakness and extend when the patient reach the non-ambulatory stage, the vital capacity decrease. The reason is that the chest wall is stiff and non-compliant, and the lung volume is now lowered, and there is a restrictive lung disease. We measure the seated FVC as long as the inspiratory and expiratory pressures, peak cough flow, saturation, lung volumes, and of course CO2. CO2 is a very important measurement to evaluate hypoventilation. To preserve lung compliance, the lung volume recruitment is indicated when FVC is less than 60%. We want to provide deep lung inflations once or twice daily. In order to do so, the patient can do an active or passive physiotherapy by self-inflating, and also he can use a mechanical insufflation-exsufflation device, the cough assist machine, as you can see in this picture. Some of the patients might need surgery for progressive scoliosis. The scoliosis might create later in life a pressure on the airways, and it might add to respiratory complications. At late non-ambulatory stages, weak cough efforts, placing them at risk of atelectasis, pneumonia, ventilation perfusion mismatch, and progression to respiratory failure, especially during respiratory tract infections. This is why we highly recommend the manual or mechanically assisted cough assist device. If complications such as atelectasis or pneumonia occur, we recommend starting antibiotic treatment early, as well as increasing respiratory physiotherapy treatment. At the same time, if necessary, inhalations of concentrated saltwater, bronchodilators, and inhaled corticosteroids can help open the airways and drain mucus plugs if present. As I mentioned earlier, we recommend monitoring a sleep lab test once a year for each patient. As soon as there are clinical signs of hypoventilation during sleep, or when the sleep lab indicates an increase in CO2 levels above 45 at night, or a significant lower saturation, or a significant apnea-hypopnea index, then we recommend respiratory support during sleep. Non-invasive ventilation can also be used during and after procedures involving anesthesia or sedation, in conjunction with assisted coughing, to extubate individuals who are mechanically ventilated for respiratory infections. The BiPAP is a device that is recommended for non-invasive ventilatory support. Signs and symptoms of night hypoventilation or sleep disorders might be fatigue, dyspnea, morning or continuous headaches, frequent nocturnal awakening, hypersomnolence, difficulty in concentration, awakening with dyspnea and tachycardia, and frequent nightmares. Some individuals remain asymptomatic despite the presence of hypoventilation. Thus, nocturnally assisted ventilation should be initiated when FVC is less than 50% predicted for age, and the maximal inspiratory pressure is less than 60. Initiate when the awake patient with daytime hypoventilation with CO2 of more than 45, during awakeness, or less than 95 in room air during awakeness. The late non-ambulatory stage is the most complicated stage. Hypoxemia is usually caused by hypoventilation, atelectasis, or pneumonias. Supplemental oxygen therapy should not be used alone. It should be used with conjunction with assisted ventilation and assisted cough machine. Whenever individual with Duchenne use non-invasive ventilation more than 16 hours a day, there is a discussion of invasive ventilation support. We strongly endorse the use of non-invasive ventilation in most clinical situations, but there are some indications for tracheostomy and starting using invasive ventilation. It might be when the patient prefers tracheostomy or he is unable to use non-invasive ventilation, or 3 failed extubation attempts during critical illness despite optimal use of non-invasive ventilation and mechanical assisted coughing, or failure of non-invasive method of cough assistance to prevent aspiration or secretions into the lungs due to weak bulbar muscles. The use of corticosteroids, the non-invasive ventilation support, the symptomatic respiratory management has extended the life expectancy. Thank you all, and now you can ask questions.